Hi everyone, I'm Dr. Diksha Pandey and you are watching Urogynecology for Beginners, a one-stop solution for all what you need to know regarding managing your patients who are suffering with urogynecological or pelvic floor disorders. We have also started a new series where we discuss the latest what is being published in our field. And I thought that while we are discussing what is latest, it will also be interesting to see what is the standard of recommendations and guidelines in various parts of the world. So in this series today, I'm going to read and discuss and give my point of view in the guidelines which are provided by ACOG for diagnosis and management of a case of prolapse. Let's see how they do it in America. Maybe next time we go to RCOG and review their guidelines so that we'll have an overall idea that what is the standard practice in various nations or various parts of this world. This is an ACOG practice bulletin meant for clinical management of prolapse, which can be done by any OBGYN. The original version of this bulletin was published in the year 2017, and what I'm presenting today is the updated version after the hue and cry and warnings over the mesh controversy happened by FDA. This guideline was published in the year 2019. In the very beginning of the document, the authors described the purpose of this publication. They state that the purpose of this joint document, which has been prepared by American College of Obstetricians and Gynecologists and also by the American Urogynecology Society, is to review information on the current understanding of pelvic organ prolapse in women and to outline the guidelines for diagnosis as well as management of the same, which is consistent with the best available scientific evidence. So very important for us to understand that pelvic organ prolapse only should be considered a problem if it is causing symptoms related to it. And these symptoms include vaginal bulge and pressure, voiding dysfunction, defecatory dysfunction, and sexual dysfunction, which may adversely affect the quality of life of that particular lady. Most women feel these symptoms of POP when the leading edge, it can be anything, anterior compartment, central compartment, or posterior compartment, when the leading edge reaches within half centimeters distal to the hymenal ring. So if it is difficult to understand, just understand when it is about to touch the hymen, that is the time patient starts feeling the symptoms. If it is well inside the vagina, though it might be displaced from its normal position, patient will not be symptomatic. If it is about to touch the vaginal hymen, then usually patients present with symptoms. Another point the authors mention here is that pelvic organ prolapse usually is due to global pelvic floor dysfunction. Now, this is a point where I disagree a bit because as our experience has grown in the field, I realize that it is not always the global deficiency. What does it mean? That if a patient is having uterine prolapse, she will also have cystocele, rectocele, introcele, and everything together. However, what I have been seeing of late and experiencing more and more, that it is not required that every patient will have defect of every compartment at one go. The reason is simple. Maybe in old women, where it is because of collagen and tissue deficiency, everything will happen together. However, in women where prolapse has happened in young women because of injuries sustained during childbirth, because of avulsion of levator ani, or because of breakage in fibers of uterosacral ligament. There can be just one compartment or two compartments which are deficient. Of late, we are seeing a lot of cases in young women where there is just cervical elongation. So I think all of us who are practicing urogynecology must must bring out our data to support or refute this controversial statement, or this statement whether it is a global pelvic floor deficiency or it can be most of the times just isolated compartment defect. One more point I would like to highlight here. It says that in women who do not want treatment for their POP, most will have no change or only a small increase in size over the next 1 year. Now, why is this clinically important? It is important because when we counsel a patient who has pelvic organ prolapse, we tell her that, of course, the surgery is not urgently required, but in due course of time, you will require either a surgical or a conservative management, because this problem with menopause and after a few years, it is going to increase. The next question of many patients is, what will happen if I don't take a treatment, or if I want to delay the treatment for 6 months or 1 year? So you can safely say, as per these guidelines, that usually within 1 year there won't be any dramatic increment in the degree of prolapse or the symptoms. I have taken the screenshots of entire pages, though I am reading a very few lines which I feel are important in that. The reason is that if you see these guidelines, turn the pages somewhere, you feel that you have gone through it. So I'm not going through the details of POP staging system which they have mentioned in detail. Rather, I will directly jump into one important thing which I felt is very interesting among the risk factors for POP. Tell me, what do you say? Does hysterectomy increase the risk of wall prolapse? Actually, it is the cause of wall prolapse. But what do you think if a patient has undergone hysterectomy at a young age? How should we counsel her about the risk of prolapse or wall prolapse, to be specific, in years ahead? The authors have quoted a study here which was done in United Kingdom, where patient who underwent a hysterectomy, they found, had a 5% cumulative risk of undergoing prolapse surgery within next 15 years. So 5% risk in next 15 years. Now this statement was about overall all hysterectomies. Now what happens to those women whom you are treating either with hysterectomy or with some conservative way for pelvic organ prolapse? The chance of recurrence or wall prolapse is much, much higher in these women. The incidence is around 30 to 50%. And it is not mentioned here, but we all know that if anterior compartment is defective, that means if cystoscopy is there, the incidence of recurrence is maximum in these women who will require surgery in due course of time, rather resurgery in due course of time. But not to lose heart, there is still a hope that literature has provided enough evidence that if you are suspending the vault, or if you are also performing the apical suspension when you are doing surgical management of prolapse, either hysterectomy or without hysterectomy, the recurrence rate is much, much lower in these women. So, finally, summarizing the risk factor for recurrent prolapse, which we have to counsel our patients about, include when the age is younger than 60 years, for patients who are undergoing vaginal surgery for POP, if they are obese, if the preoperative diagnosis of prolapse is higher, If they are already having third or fourth degree prolapse, the chance of recurrence is high. And I will add one more, if they have anterior compartment defect, these are the women who are more prone to have recurrent prolapse later in their life. However, if you do a good apical suspension, you prevent this risk factor to quite a certain extent. After discussing the basics, the epidemiology, the risk factors, the guidelines talk about the initial evaluation when a patient presents with pelvic organ prolapse. And all of us know how to take the history in detail. If you want to go through the points in history, we have one nice presentation which we have uploaded around a year ago on how to take a good history in a 5-pointer manner in a case of prolapse. You can go through it. I'm sure it will be of great help. When it comes to physical examination, I was surprised to read this, though I have been doing this for many years. However, I did not expect it to be a part of some guideline, but they also say that simply spreading the labia while examining the patient in supine position can be helpful to assess the maximum descent of prolapse. So when I start, I do not recommend it for the beginners or for the students, but usually when I have to examine a patient, I just spread the patient's labia with my left hand, index finger, and thumb, and just tell the patient to cough or push down or bear down. If whatever have patient told you symptoms, your examination is correlating with that, there is no need to put a speculum as far as making a diagnosis is concerned, the initial diagnosis is concerned. But if whatever the patient is saying that is not corresponding to your examination findings, please take your time, change the position, make her stand up, put a valsalum, and do whatever it takes till the patient and you are satisfied that what history she is telling and what examination you are able to find the findings are matching with each other. Now look at this blue highlighted part. In general, no additional testing beyond a good history and examination is needed before you start the treatment. In routine cases of prolapse, I will add. From the next section, I would really like to read some of the sentences because this is the thought and a complexity in the mind of beginners. The question is pelvic organ prolapse quantification, that is POPQ, necessary before treatment of pelvic organ prolapse? I will read what they say exactly, the highlighted parts. It is important before treatment. Why? So that the surgeon has a pre-operative comparison by which to measure post-operative anatomical success. Now, it can be for your sake or it can be to explain the patient that initially the leading points of anterior, posterior, and central compartment were here, and after my surgery, see, it has gone up. It is also important for follow-up. POPQ is used in most scientific publication on POP. This I keep on repeating to students, to beginners, that there is no research today which is done in cases of prolapse, and if you have not done a POPQ classification for them, forget it getting published. So if you are planning to do a research and publish it, you must do POPQ examination for all your patients included in that research. It again emphasizes the point that a validated examination, which is POPQ here, allows for consistency in reporting and also facilitates communication between one doctor, one care provider to the other. The outcomes can be evaluated only if we have performed a pre-treatment POP for patients and recorded it accurately. So, in this context, yes, POP is important for comparisons, for validation, for follow-ups, and also for publication. This guideline does not only talk about the surgical management, it also touches upon the non-surgical or conservative management of prolapse. A vaginal pessary, it says, is effective non-surgical treatment for women with pelvic organ prolapse, and up to 92% of women can be fitted successfully with a pessary. But this figure is more correct for the world where all kinds of pessaries are available in our region. When we have only ring pessary, we have to be more um, conservative in telling this to the patient. Very important point or the guideline regarding the follow-up of these women who have chosen pessary for the treatment of POP. If a woman is unable to remove or replace her pessary, regular follow-up such as every 3 to 4 months is necessary. Not change of pessary, just the follow-up, mind it. Annual follow-up is recommended for patients who are able to maintain pessary hygiene on their own. Thus, the guidelines, the ACOG guidelines say that pessary use is a low-risk intervention that can be offered to all women who are considering treatment of pelvic organ prolapse. This is a very important sentence to understand. Now, when is surgery indicated for the management of pelvic organ prolapse and what are the primary approaches? Surgery is indicated for treatment of POP in women who are bothered by their POP and have failed or declined non-surgical treatments. Important consideration for deciding the type and route of surgery include the location and severity of prolapse, the nature of symptoms, whether they are having urinary problems, bowel problems, or sexual dysfunction mode, the patient's general health and her preference, and also, and maybe the most important, the surgeon's expertise to do particular kind of surgery. This list is about the types of surgery which can be offered to patients. So they have mentioned 6 surgeries which include abdominal sacropulmoplexy, uterosacral ligament suspension, sacrospinous fixation, anterior vaginal repair, posterior vaginal repair, and vaginal repair with synthetic mesh or biological graft. Now see the list carefully. The much hyped surgery these days, laparoscopic pectopexy, is not there in this list of guidelines and recommendations. We still have to wait for long-term efficacy and complication rate of pectopexy to get it included in the guidelines. So you be careful about it. First question they have tried to answer is vaginal route okay for prolapse surgery? Vaginal hysterectomy and vaginal apex suspension with vaginal repair of anterior and posterior vaginal walls are needed as effective treatment for most women with uterovaginal or anterior and posterior vaginal wall prolapse. These are relatively low-risk surgeries that may be considered as surgical option for most women with primary POP. If a patient has uterine prolapse, vaginal hysterectomy alone is not an adequate treatment. We are not doing it, but I have seen people doing it. Vaginal apex suspension should be performed at the time of hysterectomy for uterine prolapse to reduce the risk of recurrent POP. And I say it should be done even if you are not doing the hysterectomy part. If you are doing some conservative surgery, then also it is very important to suspend the apex. Suspension of apex is recommended either by uterosacral ligament suspension or sacrospinous suspension at the time of vaginal surgery, and both are equally effective. Now I'm going to tell you my most favorite point in this guideline which they have mentioned, and it is about the paravaginal defects. I will read it as it is. Paravaginal defects are lateral detachments of vaginal wall from the facial condensation over the levator ani muscle. Diagnosis of paravaginal defect by physical examination is unreliable. Moreover, if the paravaginal defect is suspected, there usually is apical loss of support too. Apical support procedures may address most anterior vaginal wall defects, including paravaginal defect. This is very important and simple to understand. I keep on telling when you all ask me, what about the paravaginal defect repair? It is not easy, especially when you are doing vaginal surgery, to repair it effectively. Causes lot of damage to the patient, and it is very difficult for the surgeon to do it vaginally. So what can we do? We are actually doing it with every surgery. When you fix the vault high up, it is a kind of same line suspension as it should have been done for a paravaginal defect. And this guideline supports this, that if there is paravaginal defect, you do additional apical suspension, and that is good enough to take care of that paravaginal tissue defect. One more interesting thing which I keep on teaching always, and now ACOG guidelines are saying this, that posterior vaginal wall repair should be performed without placing tension on the levator ani muscle. So in modern day practice, we do not do levator ani plication when we are repairing the rectocele. What does the guideline say about abdominal sacrocolpopexy? It says that women who may be candidates for abdominal sacrocolpopexy include those who have a shortened vaginal length, some intraabdominal pathology which can be dealt with together, or who have some risk factor for recurrence of prolapse, like if they are younger in age and have higher grade of prolapse, and if they are very obese with higher BMI. Abdominal sacrocolpopexy with synthetic mesh, which is always with synthetic mesh, has a lower risk of recurrence of POP, but remember that it is associated with more complication than vaginal apex repair with native tissue. That's what guideline focuses and wants you to remember. Surgical complications that are more common after abdominal sacrocolpopexy include paralytic ileus or small bowel obstruction, thromboembolic phenomenon, and also mesh or suture related complication. In addition, sacrocolpopexy with mesh is associated with significant reoperation rate due to these complications. So obviously, this should not be the first line of treatment for primary pelvic organ prolapse. Now, what about the minimally invasive approach to pelvic organ prolapse? And here we are talking about laparoscopic sacrocolpopexy. And the evidence says that it takes longer time as compared to open abdominal sacrocolpopexy. And how much time exactly? It is 296 minutes, which is around 300 minutes. And do you understand how much is 300 minutes? It is around 5 hours. So on an average, we take around 2.5 to almost 3 hours to perform an abdominal sacropulmoplexy, but according to this literature which they have gathered to make the guidelines, maybe that center is doing more complicated cases, so they have mentioned an average time of around 5 hours for the procedure. However, they have also mentioned that if you do it laparoscopically, there is less blood loss and shorter hospitalization for these women. Next question is posterior vaginal wall prolapse repair more effective with the transanal or transvaginal incision? OBG people will say, is it a real question? We have been doing it always transvaginally and it works very well, and the guidelines support us that the preferred route is transvaginal only. Next question. Are surgical approaches available to treat pelvic organ prolapse in women with medical comorbidities? So here I would beg to differ. These guidelines again suggest, as the other literature which is available says, that obliterative procedure is a good choice for women who are not sexually active, who are old and who have a lot of comorbidities. But in my clinical practice, I have to find a person who has this kind of complication where I cannot perform a vaginal hysterectomy and repair fast enough under the given period by the anesthesiologist, and I have to do some procedure which is even quicker. So I usually do not do colpoclesis or obliterative procedure. I would really love to know what is your practice and what is your viewpoint about obliterative procedures in modern urogynecology with availability of good antibiotic and good anesthesia. The next part has discussed the role of transvaginal synthetic mesh for prolapse repair. And they themselves have highlighted it in light yellow color, as you can see it here. And all of us know that we are not using synthetic meshes for prolapse repair nowadays after the FDA warning. However, I would still like to read this line which I have highlighted in pink, which is, I think, very, very important for all of us to understand and to give the evidence if somebody starts contradicting your statement or your surgeries. So the ACOG Practice Bulletin 2019 says that it is important to note that the FDA announcement applies only to mesh placed transvaginally to treat POP. The FDA order does not apply to transvaginal mesh for stress urinary incontinence or transabdominal mesh for POP repair, that is for sacropulmoplexy. Very important to understand and to remember if somebody starts questioning your surgical practice for SUI or wall prolapse. Their next question really intrigued me. Is it necessary to perform intraoperative cystoscopy during pelvic organ prolapse surgery? The ACOG guidelines recommend that routine intraoperative cystoscopy during POP surgery is recommended whenever you are doing a suspension procedure with the help of uterosacral ligament or sacropulmoplexy, and also if you have performed an enterocolporrhaphy. Actually, in the beginning, when I started my career, I was doing cystoscopy for all these procedures. However, in due course of time, I have left doing this. Maybe it is time to go back and start it all over again. Next, are there effective pelvic organ prolapse surgical treatment methods if patient does not want to undergo a hysterectomy? The answer is yes. If the patient is young, hysteropexy is a good option. It can be done vaginally, abdominally, or laparoscopically. However, if the lady is old, debilitated, and does not have importance of sexual functions, Colpoclysis is also a good option and effective treatment according to the guidelines. We have discussed it earlier also. Next question is, can the occurrence of stress urinary incontinence after surgery for pelvic organ prolapse be anticipated or avoided? To give an answer of this, the guidelines suggest that all women who are undergoing a pelvic organ prolapse surgery should be examined for SUI, either with cough stress test or with urodynamic testing, while keeping the prolapsed uterus inside the vagina. And if in case the lady is already suffering with bothersome SUI with pelvic organ prolapse, both the surgeries should be performed concomitantly in the same setting. Now, let's talk about the complication of pelvic organ prolapse surgery and how to manage those. So, complications after native tissue POP surgery include bleeding, infection, and voiding dysfunctions. There can be complications which are more fearful but less common. These include rectovaginal or vesicovaginal fistula, ureteric injury, shortened vagina, and restriction of vaginal caliber. There are different guidelines. If these things happens, we have to look into the evidence and try to manage those effectively. Now, what if after surgery the pelvic organ prolapse recurs? Usually, it is called wall prolapse, or it can be also called as a recurrence. Actually, we have already discussed a bit about this recurrent prolapse in our earlier discussion. Still, I'll read this line that recurrent of POP after a POP surgery varies from 6% to 30%, which is quite high. Management of this recurrence is what we call as management of wall prolapse, and it is to be done in the similar lines. We are not discussing it here today. And with this, we have reached the final part of this guideline or recommendation, that is the summary and conclusion. So they have divided these conclusions based on the scientific evidence into level A, level B, and level C. So level A conclusion says that uterosacral and sacrospinous ligament suspension, they have not specified whether they are talking about low uterosacral or high uterosacral or both, but they say that both are equally effective in suspending the apex nicely. Among the level B evidence, many might be important for all of us as far as clinical practice is concerned. So I will read the important lines to you. Treatment is indicated only if prolapse is causing bothersome symptoms. Women considering treatment of POP should be offered a vaginal pessary as an alternative to surgery. Vaginal apex suspension should be performed at the time of hysterectomy to reduce the risk of recurrent prolapse or wall prolapse later on. Abdominal sacropexy is associated with more complications as compared to vaginal procedures. Obliterative procedure, as I have mentioned before, they recommend. However, I still have a big question mark for this one. Hysteropexy is a viable alternative to hysterectomy in women who do not want to remove their uterus. There is not much available data to tell about its safety and efficacy, so the onus is on us that we have to produce and publish now more and more data on the effectiveness and safety of hysteropexy as compared to hysterectomy, because this generation wants it. And the level C evidence says that we must learn and do POPQ examination for all patients At least before surgical treatment, pessary should be considered as an alternative to surgery. Vaginal mesh repair should be limited only to high risk people, and we have to think in our head that the risks are less than the benefits which we are going to give to our patient by doing a mesh surgery for her. These guidelines also recommend routine intraoperative cystoscopy during POP surgery wherever there is a significant risk of injury to bladder or ureter. Preoperative evaluation for occult stress incontinence must be done for all women with POP, and patients who have POP but they do not have stress incontinence at the moment should be told that postoperatively the risk of stress incontinence is there in these women. Otherwise, when they come with de novo stress incontinence, they will be agonized and complaining. So, better keep them prepared before that. I hope these guidelines and today's discussions gave you an overall idea about management of pelvic organ prolapse. What are the best recommendation, best guidelines the world is adopting, and it will help you to inculcate these points and incorporate the important positives and negatives into your clinical practice and your surgical practice also. I'm thinking to bring you soon guidelines from other parts of the world also so that we can compare and see what's happening around the world. So, with this, I hope this discussion helped you to understand it better. Thank you.